You see, the dilemma is cataract causes CME, Tinku just told us, and diabetes also causes macular edema. Does not require same kind of treatment, does not require, anti-VEGF. Sometimes other agents may also be required. So how to go about this dilemma, cataract surgery and DME? Somnath will throw some light on this.
Thank you so much, sir. Good morning. And at the outset, I thank Dr. Lalit Verma, sir, and Ajanta Pharma for this opportunity. So, as I said, over the next few minutes, I'll try to share with you my way of managing cataract surgery patients who have significant cataract who require surgery with DME. So, before we discuss any point, the first question that comes to a person's mind is how useful is this topic to me? How relevant to my practice? So we all know diabetes is increasing. And currently, one quarter of the patients of diabetic cataract that are presenting to you already have DME. Though majority of them are non-clinically significant macular edema, but 7% patients actually have CSME also. Now, why is this combination of a patient with diabetes who requires cataract and in presence of DME important? Well, the simple thing is that once you do cataract surgery, if you are not careful, the cataract surgery per se can worsen the DME. This is true for both patients with existing DME, where nearly half of the patients will have worsening of the DME, as well as patients who had DME, was treated for the same, and presently don't have DME. So, if you have a patient with a history of treatment for DME and is about to undergo cataract surgery, you need to be careful in them too, because two-thirds of these patients may have a relapse of DME within 3 to 4 months post cataract surgery. And we already know cataract surgery patients have high visual expectation. So any DME may lead to a poor visual outcome and an unhappy patient. So what causes this worsening? In a single word, it's inflammation. We know cataract surgery causes breakdown of blood ocular barriers and enhance ocular intraocular inflammatory response, and this is what causes the worsening of the DME. So then how do we avoid this situation? So there are basically two ways. One, you can keep delaying the cataract surgery as long as you want or as long as you can, and keep prioritizing DME always over the management of the cataract. But this is not an ideal situation, because as long as there is a visually significant cataract, your patient is not going to get the best vision. Secondly, if while delaying the cataract becomes matured, then it will be impossible for you to even assess the retina. So we basically would not want to delay a cataract that is visually significant just to avoid worsening of DME. Rather, we like to find a way by which we can prevent the inflammatory response so that it is blunted and the DME doesn't worsen. And there are two options. Either we try an anti-VEGF for the DME to blunt the post-cataract inflammation, or we try a steroid, which can be either an intravitreal triamcinolone acetonide or a DEX implant. Now, of these three possible agents, I feel DEX implant is theoretically the best place. Talk about an inflammatory pathology worsening the DME, we can all agree that steroids will be better choice than anti-VEGF, because they are basically anti-inflammatory agent. IBT and DEX implant, again, the DEX implant appears a superior choice because it has 6 times higher anti-inflammatory action. Also, it has a sustained effect. So, for 3 to 4 months, it will be in the eye. Not only that will help you prevent the DME worsening, but it can actually work as a therapy for the pre-existing DME. So in 2024, we came up with this, we published this paper where we basically wanted to see in our real world scenario, if we use DEX implant in a scenario where patient is having DME with cataract that needs surgery, how was the implant performing? So this was a retrospective analysis of around 20 cases with pre-existing DME and visually significant cataract. A majority of these patients were mild to moderate NPDR. Now, in during that study, I only do retina, so I used to inject the DEX implant 1 month prior to the surgery, and all the surgeries were performed by my colleague at the center, Dr. Shantanu Ganguly. So I'll share just two case examples from that series. So the first patient, a 56-year-old female who had already received 7 intravitreal anti-VEGF injections elsewhere, was diabetic, hypertensive, and also had CKD. Now she presented with this NS grade 2 cataract with severe NPDR and refractory center involving DME. So we gave an injection of Ozurdex followed by cataract surgery. 2 months from the injection, that is 1 month post cataract surgery, the DME had resolved. Vision had improved by more than 3 lines, though it was still 624 because of the chronic DME and the residual effect of that on the vision. 5 months post injection, we could make out that there was an early recurrence of the DME happening. So we have repeated the Ozurdex injection. Second case, a 65-year-old male diabetic. Again, this patient came with no history of prior injections, but had a moderate NPDR with an obvious center involving treatment naive DME. So again, we gave an injection of Dex implant followed by cataract surgery. 2 months post the cataract surgery, you can see the DME has resolved nicely. This held on till 4 months. And at 6 months, we could make out that the DME was coming back, at which time we repeated the Dex implant. So if we go back at what was the analysis of those 20 cases, what did they show? So in terms of functional outcome, the Dex implant did remarkably well with all patients having 3 or more lines of visual gain, which was sustained till the 6th month study period. And this was not just because we did cataract surgery, because vision improvement is expected after cataract surgery, but it was also because the DME did not worsen, which is proven by the anatomical outcomes, where all cases had significant CMT reduction, and that too was sustained till 6 months, with only one case having more than central subfoveal thickness more than 300 micron at the last visit. But very interestingly, now here we are talking about an expensive implant being added to the already expensive package of a cataract surgery. So the whole thing becomes a very pricey thing. So you may wonder how comfortable will be my patient for with that kind of a package. So three-fourth of the patients in this particular series, 15 out of the 20 cases, did not require a repeat injection within the 6 month treatment study period. And when we further analyze the 5 cases which actually required a repeat injection, we realize that the worse or more advanced the background DR, the greater the chance the patient will require a repeat injection. For example, there were two PDs and both of them required a repeat injection within the 6 month period. But then whenever we talk about an intravitreal steroid or Dex implant, the question of safety comes. So the in our study, our experience safe with only 2 patients having transient IOP elevation. And in both the cases, the IOP could be well managed with just topical medications. So based on the analysis, we concluded that intravitreal DEX administered before surgery appears to be a promising treatment strategy for cataract patients with DME. So before I end, I'll just like to touch two more issues. One, when do I inject the Dex implant? So if you saw in my, if you heard me, just I shared in the study that we published, our injection was given 1 month before. But there are basically two approaches. You can inject the Dex implant at the time of surgery, or you can do as we did 1 month before. Now, subsequently, there has been a recent study which was published, which is a DexCat study, which compared both these approaches, and they have found that closer you are to the time of the cataract surgery, the closer you inject at the time of cataract surgery, the longer the implant will work and the drier the macula will remain post-op. So basically, if you can, like we nowadays, what we do in our center is we inject not 4 weeks, but 2 weeks before the cataract surgery. But you can inject at the time of surgery itself. That is even better. And there is another reason for that, and this is the last thing that I would like to highlight. That is, in case you have a PC rupture or the PC becomes unstable, that is a very dangerous situation where if the Dex implant comes to the anterior chamber, it can definitely lead to corneal edema and vision loss. So this would be a suggested protocol, as Tinku ma'am said, that in case there are patients who are only having DR or no DME, you can manage, as madam said, with topical NSAID prophylaxis. If you have a patient who has center involving DME, which is existing or which has already been treated, then do consider Dex implant. So my concluding message is that as prevalence of diabetes increases, so will diabetes with cataract. Quarter of your diabetic cataract patients are already presenting with existing DME, and cataract surgery can worsen them. Based on our study, perioperative or preoperative Ozurdex can definitely help avoid worsening of this DME and lead to good visual outcome. Thank you so much.
Excellent, excellent, Somnath. Before Sabyasachi, goes to the podium, we'll have a couple of discussions based on the previous speakers. Uh, Tinku, do you still agree with prophylaxis, or anybody else can comment? Prophylaxis of CME, you touched upon prophylaxis of CME. Do you still do it? Because we have great surgeons like Tityal who, CME होता ही नहीं है उनकी आंख में कभी.
So not in all
No, because
cases.
now these things have changed so much because of technology, small incision, 0.8 millimeter, foldable lenses. So do you still believe in this age-old whatever has been taught to us when we were residents by Bromphenic, Ketorolac?
No, no, sir. There's no role of prophylaxis except in high risk cases. Like I said, diabetics is one patient, is a one subset of patients, and patients who've had CME in the fellow eye.
So all patients with diabetes, you give pre-op drops.
Generally, yes, 3 days before.
Anybody would like to react to this? Yeah.
So I have a question, sir, that to both Dr. Tinku and because in a case with the in with diabetes, sometimes you don't have such a good pupil size. It's a mid-dilated pupil. You expect that there will be some kind of handling. Would you recommend giving intravitreal triamcinolone at the time of surgery, even if there is no edema? If there is a diabetic retinopathy, but no macular edema.
So that we last
No.
Somnath. We were just talking of prophylaxis of CME, cystoid macular edema. So my thinking is that I don't know. We can have opinions from the house also. No longer we advocate by if in a uncomplicated situation of diabetes, controlled sab kuch, no longer everybody is finicky about that. You definitely start steroid. And the other thing is that all ERMs, see, you said all ERMs they require surgery or you can.
No, no, not
No,
all ERM.
yeah,
So there, I showed the
yeah, yeah.
pictures of ERMs, which would resolve very well with the steroid injections. Very thin ERMs sometimes form in any chronic CME. Very thin ERM would form. That would not lead to so much traction. So if you feel that the edema has gone down with your steroid injection, you needn't do an ERM peeling. It's just that these ERMs can sometimes cause a recurrent edema. So if they're causing a
Yeah.
recurrent or a recalcitrant edema, then they would require
So
it.
thanks. I just wanted to reiterate that all ERMs do not require surgery. Please don't counsel these patients. A lot of ERMs have 6 by 6 vision also. To Abhishek, next was yours on OCT. Uh, do how should a novice surgeon start his practice? Is OCT a must for starting a practice? Because you showed two pictures in the beginning, before and after, when we didn't have OCT, now we have OCT. Does anybody has today guts to start the practice without OCT?
So more than guts is the depth of the pocket. But if
Okay.
it allows, I would definitely recommend that OCT is something that you should not start without. Because there are so many subtle things that we miss and so many nuances. Even for patient education and counseling, I think OCT has become a must.
Or let me put it another way. Do you see any patient without OCT?
I see a lot of patients without OCT, sir. I still do, but where there is a decision making, especially a therapeutic decision making dilemma is there, always I would ask for an OCT.
So my teacher and my mentor, Professor H.K. Tiwari, used to tell that जैसे हम करते हैं ना vision, refraction, NCT, get an OCT done before patient goes to the clinician.
I
Because
almost never do that, sir. I almost never ask for OCT before I have seen the patient clinically. The vision will happen, the dilation will happen. I will see the patient only, then the patient will go for OCT. Not as a standard.
so OCT should be there preferably in all the practices,
In retina practice, definitely, sir.
all comprehensive practices also. Yeah.
Because they will take care of retina.
How do you tackle a patient if he's carrying so much of these colored charts? You see, nowadays people come with, everybody will come with those rangeen se chart leke aa jate hain na. And that somehow you showed so many caveats and pitfalls, and usme information nahi hai. So what
That
do
is
you
a
do?
real practical problem because sometimes when before the patient reaches the retina surgeon, he has already gone to 2 or 3 anterior segment practices and he has a wide field fundus photograph, he has a OCT, and half the time sometimes even the octa, and sometimes the OCT is not taken from the correct place. It's not through the lesion, so we have to repeat the thing because eventually the treatment is going to be decided by us, and that cannot be based on second-hand information.
The practical part is so difficult to convince him. Dr. Sab, kal karaya tha maine OCT.
It is difficult, sir. It's a practical point I think which you have raised, sir.
And Somnath, you talked about so much about Ozurdex, and Ozurdex. So why do you want to give it, pre-operatively 2 weeks? Because the best time is to give. You said closer it is to the cataract surgery. We at Center for Sight give.
Yes, sir, you are correct. The study also said the same. The closer you can be to the cataract surgery, day of cataract surgery, or at the day of cataract surgery itself, you give. We are giving it more because of logistical issues. I don't do cataract surgeries at my center, and my cataract surgeon is not so comfortable handling DEX implants because it's a bulky implant. So I think he's little uncomfortable with that big needle. So because of that, we are currently giving at a 2 weeks gap. But as I said also during the presentation that say you have given 2 weeks prior to the surgery and then there is a PC rupture during the cataract surgery, then actually if the implant comes to the anterior chamber, that's a risk. So as you are doing, ideal would be that the cataract surgeon does that and gives the implant if he is comfortable.
So Abhishek and other panelists. Yes, Parvez.
So, Dr. Somnath, you are talking about Ojodix. It's very costly affair. As it is, the patient is paying for the cataract surgery. Money, what I have been doing and I have found to be very safe without having any complications, that's I'm giving supraparietal triamcinolone along with in the first when you were doing a cataract surgery in the per op only, and I have found it as excellent result without having any effect whatsoever. Money, the result.
Parvez, is true that you can give choroidal route also. That triamcinolone can be given. There's no doubt about it. Just because some people have more experience with that, so I don't think so. Both of them work. Both of them work. That may be
It's a
cheaper. That's
cheaper
cheaper.
affair.
Yeah, yeah.
It's
I'm
a bit
sure that
cheaper.
may be much cheaper.
And sir, a quick comment regarding what we are discussing right now is you need to understand that we have a two concurrent disease. One is cataract, one is DME. There are two completely different entity. So what he was talking about is for the general ophthalmologist. For DME has to be well controlled before you go ahead for the cataract surgery. So I think this is the good message we should have. So whatever you choose, either dexamethasone or IVTA, it is to control the perioperative inflammation. So if you see the study period, what he was describing, if you start giving 2 weeks before dexamethasone, and then the macular edema starts coming back 2 weeks before. So if you give concurrently, and then you are delaying it for another 2 more weeks. But the treatment of DME has to be properly. So only addressing dexamethasone along with the steroid along with the cataract surgery is the perioperative inflammation we are controlling to avoid the progression of the DME.
So absolutely, as far as possible, we should try to dry the macula as much as possible. But if not, then you should not hesitate to, give this. So other thing which I wanted opinion is a lot of people still persist injecting anti-VEGF at the end of surgery. You see, that I think should not, because cataract surgery itself is pro-inflammatory. Anti-VEGFs are also inflammatory because if we are injecting peptides into the vitreous cavity. So safer would be either what Parvez says or what Somnath says.
Sir, I have a question. What you have said, why if there is no diabetic macular edema, and why not to prefer anti-VEGF rather than steroids?
Yeah,
Because with steroids you have a risk of infection, and if you have an infection, then and these intravitreal implants will
so
not
let me
help.
let me. This is a burning this thing. One by one. You prefer anti-VEGF or steroid?
The steroid.
Tinku?
Steroid.
Yeah. Some
Steroid, obviously.
steroid. So mine is steroid.
Steroid. No, there's no question about
Yes,
that.
sir. But sir said,
Sachi.
yeah, exactly, sir. No,
No, no. I understood your question is being answered only. Your question only. That patient does not have DME and he still is a diabetic. There is no need, in fact. Sabyasachi,
exactly.
actually, there is no need.
That is
There-
what the protocol I shared also.
No,
Yeah.
if the patient hasn't settled DME, means on preoperatively we have treated diabetic macular edema. Now you have a normal foveal
So you
contour.
have a fear. You have a fear that it may exaggerate.
So that also I shared that if you have a patient with a past history of treated DME, but the DME was center involving DME, even there Dex implant is preferred. And as I
The
said,
reason AG we are saying is because it's an inflammatory component. It's the
Exactly.
what is contributing to exaggeration of previously settled DME now getting exaggerated because of cataract surgery. Cataract surgery pro-inflammatory, so you have to give anti-inflammatory rather than injection. So that is the thing. Okay, we'll finish off this debate at this time.